Hi, this is Sherry Barr. I'm your instructor again for PCC's Pharmacology class, this summer course, this quick course we're taking. This is week 2, unit number 1. Today we're going to talk about the antibacterials, the penicillins, cephalosporins. We're going to talk about sulfonamides. We're going to talk about the antiviral and antimalarial type drugs. It's quite a lot to cover. This is unit 1 though, and I'll try to get everything in there that you need to know. The disease-producing pathogens, bacterial-wise, they can be bacteria, viruses, or fungi. But in the bacterial world, they are either gram-negative or gram-positive in the bacteria. The degree that the microorganism is pathogenic depends on what type of microorganism or pathogen it is and how virulent it is. Cell walls of the bacteria are very important in how we are able to treat and kill these different organisms. The bacilli are an elongated rod-shaped cell, whereas cocci are more spherical, and they can either be in clusters, which are like in staphylococcal, or they can be in chains, and those are more like the streptococci. Bacteria have no true nucleus, and they have no true nuclear membrane. Most have a rigid cell wall, though, and that's the trick in there. When gram staining became evident, it was found in 1882 by Hans Christian Gram. He was a Danish scientist who developed this study. The staining actually is on the cells of the sample that's taken to the laboratory, and they use either crystal violet or methane blue, which you may have had some experience with when you took microbiology. This looks at the cell's ability to hold the stain. If it's gram-positive, that means it's able to hold the stain within the cell, and if it's gram-negative, then that means it's unable to hold that dye within the cell. And it depends. That's also a good way to figure out which type of medications will work against this type of organism. Some of your gram-positives are your Staphylococcus aureus, streptococcal pneumonia, and your Clostridium. Those are gram-positives. Your gram-negatives are Neisseria meningitidis, your E. coli, or your Haemophilus influenza. Bacteria can also be either, how the antibiotics work to get them, can either be bacteriostatic, and those drugs inhibit the growth of the bacteria, and bactericidal, those actually kill the bacteria. So there's the different drugs do different things. Some of the mechanisms of which the antibacterial action is, you can see this on your table in 29-1 of this book. There are 5 different mechanisms. They can either inhibit the bacterial cell wall synthesis, they can alter the membrane permeability, they can inhibit the protein synthesis, or inhibit the synthesis of bacteria RNA and the DNA, and finally they interfere with the metabolism within the cell. An example of one, when the inhibition of bacterial cell wall synthesis, that takes place with what penicillin does. That's how it works against it. The alteration of the membrane permeability you'll see with cephalosporins. They're more inclined to do that. Your nystatins prohibit the protein synthesis. Your aminoglycosides, they inhibit the synthesis of the bacterial RNA and DNA. And your fluoroquinolones, those are the number 5. They interfere with the metabolism within the cell itself. There's more in your book about that if you'd like to get some more information. On your next slide there, you see this pharmacodynamics of antibacterials. Again, that's the exposure time for a drug. It's important for bacterial eradication. So you have to have an understanding of that. So the mechanism there, the MEC, that is your maximum effective connection. That's the maximum effective time, concentration-wise. You get the concentration of the drug for the longest period of time. That's the minimal effective concentration. That is necessary to halt the growth of the microorganism. So figure 29.1 shows the effect of the 3 methods of the drug dosing, so you can kind of see how that works. That's with your once daily oral or IV dosing, your intermittent oral or IV dosing, and then lastly the continuous IV dosing, which you can see that's actually the best for us. And you would use that if you have some very severe cases that you need to keep under control. On your next slide there, your body defenses, you have positive antibacterials work together to stop the infectious process. They are drug-dependent versus host-dependent microorganisms. Things that come into play there is the person's age, their nutritional status, their immunoglobulins, how their white blood cell count is functioning, your organ functions, your circulation, and your ability that all adds up to your ability to fight off the infection. Of course, we have some resistance to pathogens continues to be an issue despite the drug, and it can be just a natural resistance you have to it. There's a sensitivity to a drug. Pathogen is inhibited or killed, so that's what helps it. The natural or inherent resistant, an example of that is your gram-negative bacteria like Pseudomonas. It's inherently resistant to penicillin G. That means that the bug itself has a resistance or a natural resistance to the medication. So that's why some drugs won't work on certain organisms, and we have learned that over time. An example of that, like I said, is penicillin G with gram-negative bacteria like Pseudomonas. You get an acquired resistance. That can be something that you get from prior exposure. So you've been exposed to something like a Staph aureus, and it used to be sensitive to Pen G, but now it's evolved and it's now resistant. So it has a penicilliase to it. There's also the nosocomial infections, and those occur in the hospital setting. Then you can also have a cross-reference resistance to it. And that's why we need to always, before we start a drug, if you have a patient that comes in and has an infection, they're very, very ill, before you treat with the antibiotic, you always do a culture and sensitivity. That way you're not going to sterilize the patient out with antibiotics before you know what you're treating. And then there's a less chance to build up more of a resistance to that antibiotic against those drugs. There's been a major problem since the 1980s. There's fewer antibiotics that are being made. All methicillins have been off the market now for a while. So then we end up with problems where we have like MRSA, where you have to start treating with things. These are resistant a lot to just one antibiotic, so you have to use combinations of antibiotics. We don't do that routinely unless there's a need. When you find out, say if your patient just came in and they've got a community-acquired pneumonia and they are in the acute stage but they're not severely ill, you can treat with one antibiotic. But after that, then you're going to have to start using combinations of medications. So you'll do things like you'll use a penicillin and a cephalosporin, or things like a Vanco and a Zymox. So these are Bactrim, or with your Vanco you might use doxycycline. So you want to make sure and kill the drug completely. The effects of that are additive because they are greater than the sum of the effects of the two parts. So you get a better kill of the bacterial. They have an effect to potentiative effect, meaning that it is increasing its effectiveness of both. So it's better, the two together are better than just the one or the other. The other thing with it is your antagonist effect, and that's a desired effect that maybe will be decreased if you only used one. Examples of that is like penicillin in your bactericidal, or tetracycline, which is bacteriostatic. So you'll use the combined to get a better effect. Some of the general adverse reactions to your bacteria are listed on table 29-2. Some of those things can be allergic or a hypersensitivity to the reaction, be mild to severe. You don't want to see the severe. Those can be as far as anaphylactic shock, which you'll see the shortness of air first. That's generally within the first 20 minutes after starting the medication. And that can go all the way up to vascular collapse. You can have edema, swelling of your laryngeal. You get bronchospasm, and you can get cardiac arrest. You treat these things with epinephrine, your bronchodilators, your antihistamines. It's an emergency. You call in a code on this patient. If it's just a mild hypersensitivity, then we just treat that with antihistamine and continue to give the medication. You can get a superinfection. These are secondary infections, and generally those occur in the mouth, which you treat with nystatin. It's like a white thrush that happens in the mouth. You treat with nystatin. You can get a respiratory tract, GI or GU or skin irritations. These are generally fungal infections, and they're rare if the drug treatment is less than a week. It's usually the drugs that are being given longer. And these are just a side effect because you have changed the natural flora of those areas, and so now you've got another infection, like a yeast infection or a thrush, in addition to what you had in the first place. You can also, with these antibiotics, especially if you're giving them for long term, you can get organ toxicity, and this is both of the liver and kidney primarily, and it actually causes damage to those organs. Then you look at your narrow spectrum and versus broad spectrum. Now your narrow spectrum, you're looking, when you first give an antibiotic and you don't have your cultures back, generally you give a broad spectrum drug, and that's going to look for a wider amount of kill for the organisms. And then after you finally get, which of those drugs are like tetracycline or cephalosporins, but then you fine tune it after you get your cultures back, and then you can pick the meds that you need to give for that patient. Let's back up 1 minute on that organ toxicity. Another place you can look for your toxicity is the ototoxicity. I just wanted to bring that up because I did see that on one of your tests. Okay, let's look at the penicillins. Penicillins are a group of antibiotics that were derived from the Penicillium fungi. It was the first of the drugs effective against many of the previously serious diseases such as syphilis, your streptococcus. It was originally discovered by Alexander Fleming in 1828. Your basic penicillin is like your Pen G and your Pen V. These are for moderate to severe infections. In pregnancy, they are category B, and they're not recommended if the patient has renal failure. So that's important to know. These are broad spectrum, like amoxicillin. They're very good at treating your lower respiratory infections, otitis media, sinusitis, and UTIs. The structure of that penicillin, in fact, all penicillin is your beta-lactam. They inhibit cell wall growth and proliferation. They do this by causing cytolysis of the cell. Then there is a difference in the cell wall building and an inability for it to repair itself. Penicillins generally are well absorbed from the GI. They are protein bound, about 20%, especially when you look at your amoxicillin, which is a broad spectrum. All of these are penicillin derivatives. They're bactericidal, meaning that they interfere with the cell wall synthesis, like I just said, causing cell lysis. It's not able to rebuild itself. Contraindications to using penicillin type meds, is especially like amoxicillin, any of those derivatives, is if you have an allergy to penicillin. And these can be either a rash, superinfections, nausea and vomiting, respiratory distress. The effect of these meds is decreased with any acidic fruits or juices, so you wouldn't want them to take these medications with any like grapefruit juice or orange juice or any of these. And your erythromycins and tetracyclines, you really don't want to take those with any milk products or anything like that, because it decreases the effect. Another thing with penicillins, your penicillinase resistant penicillins, like your anti-staphylococcal penicillins, that's your dicyclooxane, nextillin, and they can be given either IM or IV. These are for your treatment of your Staph aureus infections. They are not effective on gram-negative organisms. They decrease their effect on PNG and gram-positive organisms. These are highly protein-bound meds. They are greater than 95% protein-bound. And the side effects with those, of course, are your rash. You can have an increased bleeding time with it. Again, your super infections and blood dyscrasias. Your extended spectrum penicillins, these are your anti-pseudomonal penicillins. These are a group of broad spectrum penicillins that are effective against gram-negative organisms like your Pseudomonas. These are difficult to eradicate organisms, and these actually work well on them. It's also good on other gram-negative organisms like Klebsiella pneumoniae, Antibacterials, and your protease synapse. These are drugs like your piperacillin sodium. They always are combined with a penicillin. It helps the drug. They're combined with like penicillinase drugs like amoxicillin and piperacillin will be together. These inhibit the bacterial beta-lactamase, like we talked about earlier, making the antibiotic more effective for a longer period of time. Let's go to the cephalosporins now. There's a generation of cephalosporins. These were first developed in 1948. A fungus called Cephalosporium acranium was discovered in seawater at a sewer outlet in Scandinavia, and it was found to be effective against gram-positive and gram-negative bacteria and resistance to that beta-lactamase. There are 4 generations of the cephalosporins. The first generation includes your Keflex and your Duraflex. Then you have a second generation, which is your C-Chlor and your Mandol. We use a lot of the C-Chlor. Your third generation, it includes Fortaz, and your fourth is your Maxipine. Cefalozocin, it can be given either IM or IV. It is protein bound, more so than your Cefalocor, which is given PO. The half-life of each of these is short, and it's excreted in the urine. It inhibits cell wall synthesis and produces bactericidal action, so it kills it. The things you have to worry about it is that, of course, your GI distress. It can alter the clotting time, especially in large doses or if it's given for a long period of time. The other thing is the nephrotoxicity of these medications. So you have to think about that in patients that already have a renal disorder. Let's look at your case study on that last slide. So a client developed staphylococcal infection and prescribed a cephalosporin cefepime, which is your 4th generation. Oh, I guess I wasn't supposed to tell you that yet. So which generation is that cefepime? Well, that is your 4th generation. And then you can differentiate, think about that, differentiate the actions of the 4 generations of the cephalosporin so you can have an understanding of that. Your practice question: which nursing intervention is a higher priority for the client who is taking Maxipine? And for that patient, it's to monitor the client for signs and symptoms of superinfection. So you're looking for the yeast growing in the mouth and the urine, and then you have to treat that with the appropriate medication like nystatin or something to protect them. Because these are common adverse effect with these antibiotics, so you need to culture any infected areas and then treat appropriately. One little tidbit, if you'll see on that very last slide, yeah, cephalosporin should not be administered over 30 to 45 minutes. That's general. You don't want to let it go longer than that, because then they don't get the full effect of the drug in the IV form. Okay, let's move on. We're going to look at antibacterials. These are primarily, they inhibit bacterial growth and may be bactericidal. They usually are. They usually kill the organism, but that depends on the dose and the pathogen. This is in chapter 30 of your book. Okay, this group, the microlides, the tetracyclines, the aminoglycosides, and the fluoroquinolones. I'm sorry, I can't talk very good today. These are all considered bactericidal, and they're discussed together because they are similar to penicillin, but they have a different structure. They are penicillin substitutes, especially if the patient is allergic to penicillin. Erythromycin is frequently a medication given that if the client has a hypersensitivity to penicillin. So let's look at your microlides first. That's like your erythromycin. Erythromycin was first developed in the 1950s. In a low dose, it's only bacteriostatic, but in a higher dose, it is bactericidal. It can be given both PO and IV. No IM dose on this due to the pain that it causes, and it can cause phlebitis. So we don't give it that IM route. Uses. It's used for respiratory and GI tract infections, sinusitis, skin and soft tissue infection, diphtheria, impetigo, and some of your STDs. The active ingredients. Well, let me back up 1 minute. I want you to be able to look at table 30-1. It lists doses, uses, and nursing considerations. Erythromycin is active in GI or gram-positive on gram-positive bugs, and moderately effective on some of your gram-negative drugs. You can use it on your gram-positive drugs. You can use that for mild to moderate type of infections. The drug of choice for of erythromycin is for the treatment of mycoplasmal pneumonia and Legionnaire's disease. That's a big one with that. Erythromycins are broken down in the GI, and the only way that they've been able to be broken down more is they have to add salts to these medications so that it become more completely absorbed. And even at that, when the PO route, it is still incompletely absorbed. So in the GI, only 37% of it gets in the systemic circulation. So that's why you have to take larger doses of the erythromycin. But it does work. It's excreted in the bile and the feces, and a small amount in the urine. So even in renal insufficient patients, it's not contraindicated. It suppresses bacterial protein synthesis. It has an onset of about 1 hour. It peaks in 4 hours and has a duration of 6 hours. The newer ones that they've developed, now that they're more synthetic, they have a longer half-life, and the administration time is less frequent. Okay, like I said before, allergies are rare with this erythromycin. But side effects you can get, of course, your nausea, your vomiting, diarrhea, abdominal cramps, and it's liver toxic or hepatotoxicity. It's in the high doses, or with drugs that are accumulated in the liver. So if you're taking This, along with like a high dose of Tylenol, liver damage can occur, and it's usually reversible when you DC it. So as soon as it's DC'd, and you never want to take erythromycin or any of these drugs that are listed here on your slide with clindamycin or leukomycin, because they compete with receptor sites. And so then remember when we talked about that, your receptor sites, so you have more free drug floating around out there. Okay, here are some of this leucosamides. These are drugs like your aminophylline, phenytoin, your barbiturates. Oh, I'm sorry, I take that back. These are like your clindamycin. Let's back up here. These are both bacteriostatic and bactericidal. This is clindamycin, and this is an active ingredient that fights against your gram-positive organisms like Staph aureus. It's not a good agent against gram-negative, so you don't use it for like E. coli or your protease or your pseudomonas. It is incompatible with your aminophylline, your phenytoins, or your barbiturates, and your ampicillins. So you wouldn't give it along with that type of medication. Then we get to vancomycin. Vancomycin is a glycopeptide. It was developed in the 1950s to treat staph infections. It is now our #1 medication that we use to fight MRSA. We use this along with another drug generally to fight the MRSA. It's the one that's still effective. It's also used prophylactically in heart surgeries. They'll give a dose of Vanco just prior to opening the chest, especially in patients that have an allergy to penicillins. It's given PO, but the only time vancomycin is given PO is if it's for a case of C. diff. If you have Clostridium differentiae, you need a PO dose. The IV won't help you. You got to get that antibiotic down into the gut where the fungus is lying. And you give Vanco IV for severe infections. You don't get PO for severe infections like respiratory or MRSA or septicemia. It won't work because it gets dissolved down in the gut, not where the bugs are. So you need to give IV form, and it's MRSA for that or septicemia. It is excreted in the urine when it's in IV form, feces when it's PO. It's 30% bound, protein bound. It has a half-life of 6 hours. It peaks in 30 minutes at the end of infusion. So you give this medication over an hour to 2 hours, and generally speaking within 30 minutes after the infusion stopped, it peaks. So it inhibits the bacterial wall synthesis, so it works well against your gram-positive microorganisms. This is the next one here, ketolides. This is a new classification of antibiotics. It's structurally related to microlides. It's the first drug of this type was the Ketec. It's for adults greater than 18 years of age. It's used for treatment of mild to moderate community-acquired pneumonia. It's absorbed in the GI tract. It's excreted in the feces and the urine. It is 60 to 70% protein bound with a half-life of 10 hours, and it peaks in an hour after taking it. The side effects for that, or the uses, let's talk about that a little. The uses are for acute chronic bronchitis, again, like I said, the community-acquired pneumonia, and also bacterial sinusitis. It is a you need to be aware of it with the side effects. Class 1A or Class 3 antidysrhythmics. It may lead to life-threatening dysrhythmias if you take it with that. So that would be your quinidine and your procainamide, which is a Class 1A, and your Class 3 antidysrhythmic amiodarone, or your the PO form of that, sotalol. So be aware of that. We'll talk about your tetracyclines a little now. Tetracyclines were developed in 1948. They were your first broad-spectrum drug, and they are effective against both gram-positive and gram-negative organisms and some of the other ones, like Mycobacteria, Rickettsia. They're not effective so much on staph as they are on like Pseudomonas and Proteus. They are a PO medication, but they can be given IV or IM. The IM form can cause some pain and tissue irritation, so we try to kind of avoid that. And drug and food interactions is important on tetracyclines. Do not take it with milk products or antacids because they bind and then prevent absorption. So you want to make sure and take that on an empty stomach an hour before or 2 hours after any food intake, especially any milk products. Side effects with tetracyclines include, of course, your GI distresses, photosensitivity, superinfections again. An important thing to know is you don't take it during pregnancy, and it's not given to children younger than 8 years of age because it discolors permanent teeth. So if you've seen any children like that and their moms had tetracycline while pregnant, their permanent teeth can be very discolored. I want you to see table 30-2 for some of the other indications and side effects and adverse reactions to that. Tetracyclines do come in short-acting, intermittent-acting, and long-acting. Short-acting, your basic tetracycline, and then of course you get your doxycycline as your long-acting, your fibromycin. And that one, it can be taken with milk products. It's your straight tetracycline, your short-acting there, your acromycin. That one, it binds with it, and you have no absorption from it. Next slide is your aminoglycosides. Aminoglycosides were developed in 1942 or 44, and they were first used to treat tuberculosis. It's now infrequently used for that due to the ototoxicity that can occur with your aminoglycosides. An example of that is your streptomycin. It also has become very bacterial resistant that can develop it with it's being treated on the long term for like your TB. Anyways, this medication, it inhibits bacterial protein synthesis again. It is effective against your gram-negative organisms like E. coli, your Proteus, and your Pseudomonas. It is not absorbed in the GI tract, and it can't cross into your cerebral spinal fluid. It is a good drug that can cross into your blood-brain barrier in children, but not in adults. IM and IV are the only except you can use it, the PO version, only for organisms that are within the bowel. Very similar to the PO vancomycin. The PO aminoglycoside is a pyromycin, and that's used to treat tapeworms. This has a very short half-life. You have to give it TID or QID. It's excreted in the urine. It's a pregnancy category C. It has a rapid onset of action. It peaks in 1 to 2 hours, and you need to keep good blood level checks on this because we're really looking for toxicity because of the hearing loss. The other thing that you have to be careful with is it also is very toxic to the kidney, so you must monitor your renal function closely. You watch careful with your drug dosing on that. It has many drug interactions. Your penicillins, they decrease the aminoglycoside effectiveness, and it also increases warfarin's effect. So you must give it several hours apart, and you must watch your INRs and your PTs on that Coumadin to make sure that you're not increasing the INR, the length of time, the bleed time on these patients. Now let's talk about your quinolones, your fluoroquinolones. These interfere with the DNA that is needed to synthesize the DNA for the cell. These are effective on both gram-negative and gram-positive organisms. They are very good for UTI, bone and joint infections, bronchitis, pneumonia, gastroenteritis, gonorrhea. You can look on table 30-4 for some other uses. This drug is ciprofloxacin or levofloxacin. These are primarily used for respiratory infections like community-acquired pneumonia, acute bronchitis, or acute sinusitis. Your fluoroquinolones, like I said, they inhibit the DNA synthesis on these drugs, or these organisms. They are absorbed in the GI. They are 50% protein bound. Their half-life is 6 to 8 hours, and they're excreted in the urine. You want to be sure and take these before meals because food slows down the absorption. Another thing that could cause that is your antacids. They also decrease the absorption. And your oral hypoglycemics like metoprolol, theophylline, caffeine, these effects of these are all increased, so you need to be aware of that. There's a case study on those. A client develops community-acquired pneumonia and is prescribed Biaxin. What is this? Let's think about this critically. Differentiate the common side effects and adverse effects of macrolides with tetracyclines, aminoglycides with fluoroquinolones, and then compare the drug interactions of these 4 antibiotic classifications. So I'll let you think about that one. Which teaching has the highest priority for the client taking azithromycin or a Z-Pak? Zithromax is another term for that. So which one of these things would be the most important? It would be D, because the patient should be instructed to report any loose stool or diarrhea because a possible pseudomembranous colitis has developed. Photosensitivity during sun exposure is common with tetracyclines, which should not be given to children less than 8 years old. We talked about that. And the drugs are affected by light and extreme heat. Alright, you might want to pause and take a little break. We still have the sulfonamides to go through, and then the antivirals and antimalarials, and the anthelmintics. And after we talk about those, you'll get that. So, let's go ahead and we'll start on chapter 31. These are the continuation of the antibacterials. These are your sulfonamides. Sulfonamides was first isolated from coal tar derivative back in the 1900s, and it was used in the 1935s against many of your buccal infections. This is one of the oldest agents used to fight infections that there is. It kind of fell out of favor when penicillin was first introduced. It kind of took a back seat because penicillin was thought of as the miracle drug at that point in time. These were not originally classed as an antibiotic because they were not obtained from a biological structure or a substance. They then have the properties, though, of the antibiotics, and that's why they were moved over. They are bacteriostatic, and that's due to the fact that they inhibit the bacterial synthesis of folic acid, which is needed for cell growth. Humans do not synthesize folic acid, but they have to acquire it through their diet. So that causes the sulfonamides to be selectively inhibit the bacterial growth without affecting humans' normal cells, which is good. They are effective against organisms, and they're very that cause UTIs and ear infections. They're also good for persons who have an allergy to penicillins. 90% of ear infections are sensitive to sulfonamides and work well with that. Listed on this slide are a couple of the different type of sulfonamides. There's a short-acting, and then the intermediate acting. Bactrim is one we use a lot of. That's your TPM-SMD, also known as cotrimoxone. It's a combination drug, and it is useful in treating otitis media, urinary and respiratory infections, and prostatitis. Allergic reactions can occur. You can get skin rashes, itching. Anaphylaxis with the sulfonamides is very uncommon, but you can get some of the blood disorders like the hemolytic anemia, aplastic anemia. You can have a decreased white blood cells, and decreased platelets with long-term use of any of these drugs. And one of the important things you need to teach the patient about that is when you're on these medications, you need to increase your fluid intake, and you need to take at least 2,000 mils of fluid a day. You should also avoid antacids with sulfonamides. So let's look at this case study. Older adult client who has a urinary tract infection has been prescribed oral TPM-SMX, known as Bactrim, Q12 hours. So you want to think about that. Compare the absorption and excretion rates of short-acting and intermediate-acting sulfonamides, and then describe any drug interactions that you would have with Bactrim. Your teaching practice question is, while teaching is a higher priority for the client who is taking Bactrim, so which one would be your higher priority of that group there? And the answer is A. You need to make sure that they have an increased amount of fluid intake when taking those, and that is to prevent crystallization in the urine. And ototoxicity is not common with sulfonamides, but photosensitivity is. Also remember about not taking any dairy products or antacids at the same time as you take these sulfonamides because of the decreased absorption. Okay, last part of Unit 1. Alright, let's talk about the antivirals. Viruses are more difficult to eradicate than most of your bacteria. A virus is an elongated intracellular organism, and it just uses a regular healthy cell to reproduce. Viruses enter healthy tissues, and then they use their DNA and their RNA to make more viruses. So they're a nasty little creature. Their method of transmission is coughing and sneezing, so it's more of an airborne. Like I said, the process of replication, it replicates itself within a healthy tissue using that cell's own DNA and RNA then to replicate more viruses. The signs and symptoms generally are headache, fever, cough, nausea, vomiting, diarrhea, fatigue, and muscular pain, flu-like symptoms. There are vaccines to prevent us from getting these viruses, things like the smallpox vaccine. We've got vaccines for chickenpox, for mumps, for rabies. These are developed to prevent diseases from spreading. The influenza vaccine, influenza virus vaccine, it has to change every year due to the way that the organism sets itself up. So they have to take and treat you with a drug that is basically trying to change itself. So each year they doctor it up a little bit to make sure that we're going to still get the antibodies that we need to do to prevent us from getting that flu. They are made in eggs, so we always need to check for allergy to eggs. The success rate of these vaccines, you'll hear people talk about how they took the vaccine and they still get the flu, but you need to encourage and let them know, well, it's probably a milder version than you may have gotten. In healthy children and healthy adults, it's generally 65 to 90% effective in preventing the influenza. In the older adult, it's generally about 60%, unless there's multiple health problems, and sometimes that can be a little less even than that. Your antivirals for flu, they're used to prevent or delay the spread of the viral infection, especially the influenza A and B, which you'll see on page 461. It's also, we have antivirals to help prevent CMV, which is their cytomegalovirus. These are all non-HIV antivirals. There's HIVs are listed on a different chapter. This chapter deals with a non-HIV type antivirals. And then on your next slide there, it gives you a few examples of the different drugs that you can take and some of the side effects with it. Romantadine, that one is used a lot, and the side effects of that, it's a PO pill. Insomnia, depression, some anxiety, confusion, ataxia, maybe some slurred speech with that. Some of the other problems you might have if you take the Tamiflu, that is a very good drug to help prevent or at least delay the spread or the start of it. And that inhibits the viral replication, but it has to be given within 48 hours of onset of symptoms. For treatment of antivirals, we can use the gamma globulins. These contain antibodies that are found in the blood. An example of that is your IgG. The the IM dose, that provides a passive immunity. Those are your human immune globulin. It's a single dose, and it's given to protect for about 2 to 3 weeks. And it can be repeated in 2 to 3 weeks. You can have another dose. But if you're needing an immediate immunity, you go with the IV form, and that too will last about 2 to 3 weeks, and it can be repeated. There are topical non-HIV antivirals. There are 3 of them. One of them is listed here, and these are to treat herpes simplex virus. On the next page there, you have your purine nucleosides. These drugs are effective in combating herpes simplex virus. It's also good for your herpes zoster, which is your shingles, your varicella zoster, which is your chicken pox, and CMV. Your ribavirin, that is one of those. It was first marketed in 1986. It's used to treat respiratory syncytial virus, which is your SMV, in children, and it's administered through aerosol. You have your acyclovir. This is a drug that was developed to treat herpes simplex. It was first developed as an anti-neoplastic drug that was found to be effective against your herpes virus, especially your HSV-2. It's also good for your shingles and your CMV. Your side effects to that are your GI distress, headache, confusion, depression, tremors. Some of the nursing interventions, you need to make sure you administer the IV acyclovir over 60 minutes. You want to monitor the CBC, your renal and your liver function tests, and your urine output. You monitor your blood pressure, and you're also looking for these with a super infection. Increase their fluid intake to help move all this through, and instruct the patient to practice abstinence and use condoms when it's being used to treat the herpes simplex virus. Now let's talk about your anti-malarials. Malaria is a protozoan parasite. It's carried by infected mosquitoes that then bite you, and it's still one of the most prevalent protozoan diseases in the world. The incubation period is 10 to 35 days. That's due to the 2 phases of development. The first one is your tissue phase. There's no symptoms of that as it invades the body tissues. There's no clinical symptoms until you get to the second phase, which is your erythrocytic phase, and that's when the organism is invading the red blood cells. At that point, you have chills and fever, sweating, you have flu-like symptoms. In the world, there's about 200 million cases every year. Here in the U.S., it's mainly confined to people who have entered the country from somewhere else or have traveled to where they were exposed to the malaria, the mosquitoes. Treatment for this is used with combinations of drug-resistant malaria. We do prophylactic measures, and before a patient or a person travels out of the country, they can be put on Primaquine, which helps with that. It's a synthetic anti-malaria drug. The first drug that was used for treating malaria was your quinine. It was developed in the 1820s, and it was used all the way till the 1940s till they developed some of the new synthetic type medications, which are also listed there. And then with less side effects, because the side effects were severe with the quinine, but it's a good drug. It's a lot of GI distress, some vision changes, dizziness, confusion, even seizures. You can have 8th cranial nerve involvement when you get tendinitis with that. You can have renal impairment, blood dyscrasias. You can go as far as it can cause cardiovascular collapse and decreased respirations. So that's why it's some of the newer drugs, the synthetic drugs like the hydroxychloroquine, which is your Plaquenil, that has much less side effects and adverse reactions to worry. You still get the GI distress, the mood and the mental changes, maybe some blurred vision and some blood dyscrasias, but you don't get that renal involvement so much and the cardiac collapse. On your anti-malarias, your nursing interventions, you need to monitor your kidney and your liver function. You take your meds with meals to prevent the GI distress. You report any vision changes. You must avoid alcohol, and advise individuals who are traveling to these endemic countries that they need to take a prophylactic medication. All right, now we'll talk about the antihelmintics. Anyways, these are your parasitic worms. There's 4 groups of them. You have your tapeworm, your flukes, your roundworms, and your tissue roundworms. These are large organisms that feed on the host tissue. The most common site for infection is in the intestine. You can also get these in your lymphatic system, your blood vessels, and liver. These parasites, they enter your system through food, contaminated food, especially your meats and your fish. These medications are usually given 1 to 3 days to correct it, except for like in the case of pinworms, that's a 7-day treatment. Side effects to this is GI upset, some dizziness, drowsiness, headache, and weakness. Your nursing interventions is you teach the patient to take these after meals to help prevent some of the GI distress, and you need to encourage good hygiene and warn against driving motor vehicles while on this medication. I'll let you review the case study on here, and we'll just go to the practice question. Question 1. Which is the most appropriate nursing intervention for a client who's taking melphalan and Panaquil? The answer to that is B. You need to assess the client's hearing. You're looking, because a lot of your antimalarial drugs, they affect the 8th cranial nerve, and they can damage and cause ototoxicity to that. So just so you know that. Monitoring of stools and taking showers is not necessary with antimalarias, but they are appropriate with the antihelmintics. Pap tests are not related to antimalarials, but because for female clients with genital herpes. Alrighty. So one more question, I'll let you review that, and that's the end of this week 2's unit 1, and we'll get back and we'll do unit 2 for this week next. Thanks, bye.